So for many of you who have heard me speak before or seen some of the things I've done, you'll see this is a bit of a contrast to it. But if you remember, what we're trying to do all this time is to solve the question of, is there a way to accurately and consistently dose cannabinoids across disease sets over time? With that being the question that we're trying to solve, we're doing it by the clinical experience that we're having working with patients. Let's go back. Working with patients through Aunt Zelda's, the preclinical research that's going on with Complutense University and other researchers like Didi and others, and then also through Zelda Therapeutics, which is the hat that I'm wearing here today, where we're actually funding the clinical trials and the preclinical work that's going on to prove out some of these theories so that we can answer this dosing question and create solutions for patients. So this is a collaboration that went on between Spain, California, and Australia. So let's go here. So there's been a lot of work done in the past showing the anti-tumor effect of cannabinoids. In most cases, the ones that have been studied have been using pure compounds of CBD and THC. So, and there's fantastic evidence of that. But when you get into the human trials and human looking at the anecdotal and the experience that we're having working with patients, this is not necessarily the case. So what we've done is we've hypothesized that whole plant extracts are in fact more effective anti-tumor tools than pure compounds. And why do we believe this? We believe it because as our previous speaker, and excuse my typo there, because as our previous speaker has said, there are hundreds of compounds that we don't know even what they are yet. Now apparently we do have ways that we can test, and I look forward to collaborating more on those things with you moving forward, because it's all about solving this conundrum. So because there's other cannabinoids in there, and there's other cannabinoids within the plant itself that contain anti-tumor properties, such as the THCA, CBDA, and et cetera, et cetera. There's also other non-cannabinoid compounds within it that activate the receptors, such as beta-caryophyllene, that has been shown to activate the CB2 receptors and also have effects on the tumor response as well. So because there's so many things that have not been studied, how can we reduce it down to a pure compound and say this is it? Because if it doesn't work on one, does that mean that there's no other solution? Well, last time I looked on Seed Finder, there were over 10,000 different cultivars out there. It probably boils down to quite a few less, but depending on where within the greenhouse it's being grown, what part of the hill it's being grown, what time of day you pick, all these different factors, it greatly influences what the actual compound is going to contain within the medicine itself. There's also evidence already in things like Marinol that is a pure compound, or it's a synthetic in this case, that it does not work nearly as well as a full plant. So why would we think that it would work in other areas as well? So the aim of this I'm looking at breast cancer in this case, and we're going to be concentrating on the subtype of HER2 positive in particular. However, 1 in 8 women will be impacted by breast cancer in their lifetime. And as you get older, this risk factors go up considerably, as you can see, and we are an aging population, so this is a considered problem moving forward. An estimate of the costs for this, moving forward, are, at the moment, we're spending in excess of $15 billion a year treating breast cancers, and as we move to 2020, and that's in 2010, so that's already outdated, and as we're now closer to 2020, we're looking at an excess of $22 billion a year to extend the life, and a great percentage of that spent in the final year of life for a lot of these patients. So we need to do something about this. So there's been, right now, HER2 positive, ER positive, PR positive, and then, of course, the triple negative are the 3 major subtypes, without getting into all the genetics and the anomalies of each of those in their cases. So we have the targeted therapies for ER and PR positives of tamoxifen, which many people choose to take as part of their therapies. In the HER2 positive, the RTK targeted, which is lapatinib, is pretty well the standard of care. In both cases, it's with or without chemotherapy and or radiation, depending on what your doctor has recommended for you or your oncologist. Triple negative, there are no targeted, so chemotherapy is really the only option for these. So if we're going to look, first of all, so what we did is, I'm going through the methodology right now, is we started out with two compounds. The first one was a pure THC compound that was sourced from THC Farm. It's very typical, used in a lot of different research projects. And then the second was, and I still have no idea how our extract got to Spain, but Aunt Zelda's extract from California, we selected one that was not extraordinary. We did not pick the one that was like, ooh, this is going to have phenomenal numbers. We picked an average that we may use as a starting point with a cancer patient. And we only, remember, in this study, we're only really concerning ourselves with the THC, so I'm not showing you the whole profile and the terpenes, et cetera. This actually happened to be one called Purple Urkel. The names don't even get me started. But it was about 55% THC within this. And what's important is that we use the same concentration dose in both in vivo and in vitro, so that the differences will only be responsible based upon the pure compounds versus the full plant extract. All these numbers, the first labs for Aunt Zelda's were done by Sonoma LabWorks, which has been verified multiple times at other labs for the accuracy of their numbers. And in this case, both of these compounds were double-checked through Cana Foundation in Spain. So what we did is we started out, of course, and I say we, I absolutely have that's not a real we, because I didn't do it. This was all done in Cristina Sanchez, Manuel Guzman's lab in Spain. But what they did is they started out with the cancer cells in Petri dish, which is pretty typical, and they were incubated with THC or the vehicle, which in this case was sesame oil, or the THC extract for 24 hours, and then they were subjected to the MTT of putting the yellow in what lights up what's still alive will be blue, using they're able to identify which cells are still alive and the viability. The intensity of the blue tells them the viability and how many cells are alive. And this was the first results we had on the HER2 positive, that we showed pretty clearly that the full plant extract at the 50% mark, which is really what's most significant here, we had far greater cell death with the full plant extract than with the pure compounds. And then these are two different HER2 positive breast cancers, with the BT474 and the HCC 1954. To move forward on that, we then went ahead and tested on the triple negative, because even though it was not initially the focus of this, we know that we have to check all of them, and there are no other alternatives at the moment for targeted therapies for this particular type. So it's imperative that we find something to help this group of sufferers. So at this point, we also can show once again that the THC extract is more potent than the THC pure compound in decreasing triple-negative breast cancer cells. So then it was time to move on to the mouse models. And I'm not going to even pretend to understand exactly all of the things, but I'll just explain the way it was explained to me. What was going on in the process is that these breast cancer cells, in this case it was the BT474, were injected subcutaneously into the mice that had been that were immune deficient. They'd been nude mice, is the term calls it in this case. And they were, when the tumors achieved, they were checked on a daily basis, and when the tumors achieved the 200 cubic millimeters, then they were then ready to be treated. They were divided randomly into 7. There were 7 in each group, put into these 4 different, the vehicle, once again, the THC pure compound, our extract, and then also with the lapatinib, which, as we mentioned before, is the RTK targeted therapy for this type of cancer. And what we found was that if you can look, it's very, very clear here. Excuse me, I went back a slide. Let me go back up. It's very clear that the full plant extract was far more effective in killing cancer cells than the pure, which was really much more statistically the same as the vehicle in this case. And then when we moved on to then comparing it to the lapatinib, once again, the lapatinib and the THC-rich extract performed almost statistically identically in killing the cancer cells, which is very, very promising to now see what we're going to do and run and see together synergistically to see how they work in killing the cells. If we can get even a greater, similar to what the same lab discovered years ago comparing TMZ with THC and finding that each one worked very well on its own, but it was a 50% increase in apoptosis when they were combined. So what are our next steps on this? So next we will be comparing the THC versus the THC-rich, of course, obviously in the ER-positive and the PR-positive breast cancer cell lines. We're then going to do the same exact set of experimentations with CBD, pure, and CBD extracts. There's a huge amount of noise around CBD and CBD pure compounds with people. There's a lot of salesmen and marketing going on around this, and the evidence just is not showing that using these pure compounds is giving anywhere near the medical benefits that we can achieve using full plant in any of these environments. And a lot of it's for the reasons that we just don't know what we don't know yet. So we're then going to go ahead and compare the different combinations of the major cannabinoids, and then including with that also looking at some of the other compounds that are within the plant and seeing where we can add those in. We'll be doing a combination of cannabinoids with standard therapies to see where we find the best numbers. We got a lot of work to do, and then validating, of course, all the results from the in vitro into the in vivo. And just a very quick presentation. I just want to thank, obviously, the hard, heavy lifting in this study was done by Christina Sanchez and her team, in particular Sandra, who was doing all the gavage and doing the autopsies and doing all the testing on it, which we're very, very pleased with. And then, of course, our team at Aunt Zelda's that has worked very hard over the years in creating these wonderful compounds to help treat cancers. And I beat the time. Thank you very much. Yeah, so if anybody has any questions, I'm more than happy to see if I can fake my way through it. Thank you. Yes.
So the pure THC extract, how was that extracted?
That is an ethanol extraction. We have found from our experience working with patients where we've actually done an experiment in the past where we took the same plant, had it extracted with the same crop of plant. We had it extracted with CO2. We had it extracted with ethanol. We compared that same results on patients, and patients did better on the ethanol extract using the same than they did on CO2.
I was actually,
so that was an ethanol extraction.
Comparing, though, the THC farm, that was an extract that you were comparing.
That was a pure compound.
And how was that extracted?
That was an isolate, and I have no idea the answer of that.
Interesting.
Short path distillation. There you go.
Interesting.
That's what it was. Thank you.
My wife has stage 4 breast cancer, metastasized to 5 tumors in her liver. I turned to you last year, and it worked. She has no evidence of any cancer in her body. And this comes from the head of the breast oncology department at the University of Colorado, who is aggressively ignorant and aggressively opposed to cannabis. Having said that, my question to you in follow-up to yesterday is, what now? Talk to me about a maintenance dose.
Yeah, maintenance dose is a very interesting conundrum also, and I do love that word because it seems so appropriate in this environment that we're in right now. What we've been doing with patients as a general rule, and like I said, general rules are broken. They're the medium. There's people on this side and this side that we do different things with. But for the average patient, what we do, especially when they respond as well as, for example, your wife has, without getting into specifics because it's a little slightly different than this, but to say what we usually do is after we have 2 full cycles of NED, which usually is between 6 months and a year, we'll start a titration down to about between 10-12% is statistically where it's working out on a graph of what the highest therapeutic dose was, and we leave them at that maintenance dose indefinitely. And now when we have patients with quite a few cancers, what we're doing is when we see that there's an ID1 gene involved, and I have told already that I have a little bit of a girl crush on our next speaker because of his work with the ID1, and we've taken that forward and said, okay, we're in a human laboratory in California. Because of the lack of regulation, we've been able to do phenomenal amount of work with patients, with their consent, of course. But when the ID1 gene, we're able to, and a lot of breast cancers we're able to flip that and have very high levels of, relatively high levels of CBD in comparison to THC. Anybody else?
We still have time for a few more questions.
Yeah.
Relative to typical therapy, which we all know is very time-consuming and exhausting and toxic, and its cost, can you comment on the cost of this type of regime versus what we're typically seeing in medicine?
Right. First of all, I actually gave a presentation a couple of years ago where I took some of the standard, dosing protocols that are out there on the internet and in mouse models and other things, and I extrapolated them forward and showed on a chart what that would mean for human consumption, and it was ridiculous. You cannot take from mice what you would give to a human. Having said that, though, what we have found over our years of experience in working with the plant and working with patients is that we've been able to get a pretty good idea of what the ratios of the major cannabinoids, what the terpene profile, to the best of our ability to understand it. We test for about 33 terpenes right now, I believe is the latest number. And we're able to look at that and create the regimen for the patients. However, a lot of it is based upon the individual comorbidities, other treatments going on with the patient. You can't really just say what it would be. But I can tell you that a patient, a woman probably age 45 with breast cancer, let's say she has HER2 positive or breast cancer, she can expect to spend below $500 a month during her peak treatment, maybe even a lot less than that. I have one patient, for example, one breast cancer patient right now that came to us at stage 4. She was really circling the drain, so to speak, and she is able to successfully, on 100 milligrams of CBD and 30 milligrams of THC, along with the other profile of the plant, she's able to have had extreme reduction in her tumor activity and is now living a pretty healthy life. So I would say at that, if you look at the cost, somewhere around 7 cents a milligram, 9 cents a milligram, then you can just run the numbers yourself and figure it out. Yes, but to your point, it's a very inexpensive way to save your life, and it's a much more comfortable way to do it. The only problem is insurance doesn't cover it, and these are populations that are usually off of work because they're sick, and they're the most at risk, even when treating the children that might be on these higher doses. A lot of times, nowadays, to try to live in California on one income is almost unheard of. The mother or the father, somebody has to stop working to address the child's needs. So right at the point when they're financially most at risk is when they then have to take on treatments that are not covered by insurance. So it's a real problem. Yes? Yes.
Thank you, Mara, for the work you're doing on the front lines helping patients and now on the back lines with the research. I really appreciate it. There's a concept that's been spreading through the medical cannabis world that THC is a bad thing for estrogen-sensitive breast cancer. And I've looked through the literature to try to find any evidence of this and haven't been able to. Seems like your research also disputes that. I wonder if you could comment on this kind of thought process and how it's been spreading and what you're seeing clinically.
Yeah, I would say that, first of all, thank you. I am another fan of yours, as you know. And we have found that there's a lot of rumors out there, and usually what we can come back to is they're either promulgated from the pharmaceutical industry or from the naysayers or whomever is trying to keep people away from using cannabis as an option. But what we have found is that you can keep the THC levels pretty low in the breast cancers and do a lot more with the CBD and get the same effect. But we have not found that any of our cancer patients have had increased tumor activity as a result of using THC. Zero. Yeah. I've had patients where it hasn't worked, but I haven't, and it's probably because we don't know enough about what the content of that actual medicine is, but I've never had a patient where it's grown as a result of using the medicine. Yeah.
Have you seen any examples of people developing resistance, meaning recurrences while they're maintaining themselves on maintenance doses?
Yeah, I think what happens is people become where they don't no longer having the therapeutic effects depending on what the effects are that they're going for. Because when you are using the cannabis therapeutically and you get to a therapeutic dose, you do not have to feel disassociative, you do not have to have the psychotropic effects necessarily, et cetera. You're able to do an awful lot without, because you titrate up to the point where you no longer are able to adjust to that dose, and then you know to back off a little bit because you've exceeded your therapeutic dose. And as a person improves, their health's improved, the dose can go down because otherwise that same dose will start making them feel more psychotropic effect that they may or may not be interested in. But what happens is over time, you become where you're acclimated to it. And one of the things that we do about it is we try to keep our medicines very similar in their profile for treating different disease sets, but we'll change them up so that the people are constantly being having different medicines that they're getting. And in addition to that, after about every 6 months, we suggest that they titrate down. They go down to nothing. They spend about 48 to 72 hours off of any cannabis whatsoever, and then start back up again and find that they're able to, once again, increase and have their tolerance be much lower and start having results again from the medicine. Yeah. Thank you.